In broad terms, what the Collaborative is supposed to do is bring together people who deliver care, whether they're the frontline provider or the administrators involved in that, or for that matter, some of the more broader policymakers, and to share information about healthcare delivery in terms of how the care is delivered, complication rates, outcomes, costs. And by pooling the data and very openly looking at it together and discussing trends that emerge or interesting results that come out, identifying particularly innovative ways of delivering that care.
Starting with a group that was convened by the CEO leaders of all these organizations, and that they self-funded with this common goal of sharing, learning, accelerating, improving how we give our care and making it more affordable, more accessible on a population basis, totally different.
And the thought is that by collaborating between healthcare systems that really in many ways are very similar in terms of the climate and problems and challenges that they face, that hopefully we won't each be reinventing the wheel individually and will instead be pooling each other's cumulative knowledge and trying to get to our goals faster.
It couldn't be more aligned. Why? Because it really is the product of our leaders' work. So this is about learning from the best. So the ability to convene this particular group of A players in the nation with a shared vision to move to population health and look at our practice, eat humble pie, recognize that through sharing we can accelerate and move to better care, fewer complications, lower cost, and bring what might take 10 years down to a couple, 3 years. To that kind of philosophy and that kind of shared cultural mindset of this group, totally different than the other collaboratives I've been involved in. We depend on this place for our friends, family, and ourselves. And so I think having our processes be exceptionally well designed, very robust and resilient and reliable is something that gets these amazing results.
I think there's a number of examples where we've seen ideas that have come out of the high-value collaborative that we've been able to bring back here. The one that comes to mind is the length of stay initiative and the patient messaging. And I think we've sort of rewritten a lot of our scripting to the patients and tried to provide a much clearer overview of what the timeline of a hospitalization should look like. This is what's going to happen the day you show up. This happens the day of surgery. This is what your recovery is going to be like. This is what happens on day one. This is what happens on day two. And this is something that one of our partners has done very, very well. And I mentioned earlier, have seen some very significant reductions in length of stay that haven't affected patient quality outcomes at all. And since we've started doing this here about 1.5 years ago, without really changing anything else but our approach to patient expectations, we've managed to drive down lengths of stay significantly in knee replacement. And so there's a very tangible example of something that I don't think we would have come up with on our own. So I think the two most unique contributions that Dartmouth-Hitchcock has made, and they're significant, are in terms of shared decision-making and patient-reported measures. These are the two areas that I think that Dartmouth really is in the lead nationally and internationally. These decision aids really are meant for people who are facing decisions where there are multiple options and it's unclear whether one option is the best for everyone. And in this manner, in this area, Dartmouth has really led the way. We've incorporated this across medical conditions in the center, and other collaborative partners are looking for advice on how to do this in their own backyard.
All of us need to look at our work. We need to look at our role in the processes that we work in. And we need to really be open to the idea that by sharing our performance and really looking at the data deeply and looking at others and being open to the idea that others might be doing it better, every one of us has opportunities to contribute to getting better results, avoiding complications, and doing it at a more sustainable cost.
I think anytime we take something from the high-value collaborative and try to implement it locally, we make it very clear that this is something that's been done elsewhere and has been shown to be beneficial. I think that's reassuring to our staff to know that we're not completely reinventing the concept and that this has been tried elsewhere. I think in addition to that, inadvertently, we end up adapting and modifying the concept to our own geography and our own area.
This is work that's critically important and we need to be doing because we don't have the luxury of time. We have to accelerate this. We can't do it fast enough. We are at a point where it's not a luxury to improve and get our quality right and bring our costs down. The changes going on in healthcare are such that now it's a minimum criteria of even a survival issue.
And I think, first of all, people really need to know that we're doing something quite unique in healthcare. And I think they need to know that when changes happen in the clinic, it's for a reason. It's because we're learning from someone else who has done this, and as well as we do it, it can always be done better.